Welcome to HealthWise, the weekly medical broadcast produced right here at WTVI, the Charlotte's Region's PBS station. I'm your host, Joey Pop. This week we address back pain today and tomorrow. With us from OrthoCarolina is Dr. Ronald Vandernoord. He plans to review back pain from a non-surgical perspective. He also wants to share with you what he calls emerging research. Welcome back. We're going to address during this hour non-surgical procedures. Right. I'm sure the viewing audience likes to hear that. So there's a whole hour of that we can address, huh?
Great. Yeah, looking forward to it. Appreciate you having me back.
Oh, and this is his second appearance, and we thank him for being back here. As always, you're welcome to join the conversation. A little bit later, we're going to take your telephone calls with the number that you see on the screen. And then also you can email me, and I have my PDA with me. Write to jpop@wtvi.org. That's J-P as in Peter, O-P-P @wtvi.org. We thank you for bringing these slides, going into the growing issue of back pain. Just how significant is back pain? You know, these topics are not new to our viewers. We address a lot of back pain, but it has to be, what, the #1 concern in this country, if not close to it?
Absolutely. It's the #1 complaint among adults in the United States of America is back pain.
How many Americans suffer with some form of back pain? Any idea?
Some statistics say of the 100 million, 220 million, the 100 million will suffer with back pain, and even 12.5% or 12.5 million of those people will have chronic back pain, which lasts for greater than 6 months. So it's a prevalent problem.
And the question always comes up, how soon should we go see a specialist like yourself when we think perhaps we have a little backache? You know, acute is the term here, right? That it's, how early or how soon is the term acute?
Basically, the answer to your question is because it's such a common problem, statistics say that over 50% of people will have back pain at some point in their lives.
50% of us.
And some statistics say up to 80%. So, you may be lifting a suitcase out of your trunk at the airport, or you bend over, or you're shoveling in the garden. And so just because you have the onset of back pain, more than likely that's related to a muscle or ligament problem. And so, to treat that with anti-inflammatory medication or rest, I think is appropriate. There are a group of symptoms we call red flag symptoms, and those are things that if you have progressive numbness, tingling, or weakness, problems with your bowel or bladder function, or problems with your balance, that means we're talking about something that's a little more serious, and that's definitely an emergency or near an emergency where you would need to get to trained medical help right away. But for the average back pain incident, you can try to ride that out and see if it gets better on its own, because most will get better with time.
With time, how much is time?
Usually 6 weeks. We usually give someone 6 weeks.
So be patient with it.
Right.
6 weeks, and if you should have a little issue, don't feel that, oh my goodness, I'm going to have some surgical procedure.
Absolutely.
That would probably, I would think, be the #1 concern for someone who has not experienced a problem in the past, and all of a sudden they feel like, oh my goodness, I've done something, what's next?
Right.
I have to see a surgeon?
I'm not a surgeon, and the topic of today's conversation is the non-surgical management of back pain. And I would say that, again, statistically, 80% of people that have back pain are not going to need an operation. And so I'm not trying to discourage folks from coming to the doctor, but if you have back pain and you're concerned about it to the extent that you're really nervous, or you think that you may have fractured something, or you're just, you want to be put at ease, then go see a trained professional. But typically, unless you're having those symptoms we just discussed, you can allow time to work it out. I mean, I'm sure you've had back pain. I've had back pain. Again, the statistics say that at some point we'll all have it to some degree.
And just be smart about it.
Right.
And don't be afraid to seek the help.
Absolutely not.
And that's exactly what the hour is about. So we thank you so much for joining us. Let's get right into it. Dr. Vandernoord has also brought us some slides. So let's go ahead and go to the very first one. The spine pain burden. We've touched on a little bit here.
Yeah, the reason we use the word burden is because it's not just it's not just a burden to those people that suffer from the pain, but it's also a socioeconomic burden. It's the most common reported pain among U.S. adults. Again, the 50% of the population is probably going to have back pain at some point in their lifetime. Katz did a study in JBJS in 2006 where he estimated that $100 billion in direct costs to low back pain, and that doesn't include indirect costs like the money lost when people miss work.
Now, what is CATS? You just referenced CATS. I'm thinking of our transportation system.
No, that's the name of the gentleman that did the study.
Oh, see, I didn't know. K-A-T-Z, I bet,
yes,
right?
Sir.
Okay, gotcha.
Yes, sir. Sorry,
I told you I was going to ask you questions that perhaps would be kind of like, why did he ask me that?
Yeah, no, I apologize for not making that clear.
All right, let's go to the next slide. Source of pain.
Yeah, the key is we want to find out where's the pain coming from, and just like a detective tries to figure out what happened, or a car mechanic tries to figure out what's wrong with your car. When you come in and tell me you have back pain, I'm going to ask you a whole litany of questions like, where does it hurt? When did it start hurting? What makes it worse? What makes it better? And then we combine that with a comprehensive physical exam. Where we can, do a thorough neurologic evaluation and see if we detect any changes in your reflexes or your weakness. And then we assess your function. How has this affected you as a person? What activities of daily living has this affected? What, your ability to perform your job? And then, often in this healthcare environment, we'll also add diagnostic tests such as imaging studies or x-rays, just to make sure that you haven't fractured something. And if we need more advanced imaging, there's CT scan and MRI, which most people are familiar with. And then the last category is the electrodiagnostics, and that's where we can specifically test the nerves.
Is that painful, by the way?
Everyone's pain threshold is different, but it involves sending some shock waves through the nerves, as well as then, if indicated, a pin study where they do needles and test the condition of the muscle.
But that's one of the last stages of testing.
Generally, yes.
Yeah. All right.
Right.
Next slide, guiding principles. What does this mean?
So if I want the viewer to come away from this show with one thing, it's this slide right here.
Okay.
An effective treatment, all right, will depend on an accurate diagnosis. So we need to know exactly what the problem is before we can effectively treat it. And I would encourage you to challenge me or whoever your healthcare provider is, doctor, what's my diagnosis? And that's part of what we'll go into is how do we confirm what that is.
I am so glad that you mentioned this because that has to be the #1 goal here.
Right.
I've just heard people going to doctors and they're feeling, okay, I don't know if I communicated, if I had good communication with this specialist, or if I feel like I've gotten a proper diagnosis. But that's the bottom line. And if you feel like you're not getting it, what's the advice? Make sure, just be persistent.
Yeah, I mean, that is absolutely the bottom line. And you can look your doctor right in the eye and say, doctor, what is my diagnosis? And there's sometimes that we have to say, I'm not sure, but we're going to run this test or we're going to do this thing to try to further, it's a process. It's not so clear cut. Sometimes it is, but a lot of times we have to go through a process to really try to identify what we call the pain generator. What is causing this patient's pain?
Great. I'm so glad that you mentioned that. And have to be patient with that too, right?
Yeah, that's why we call them patients. No.
There you go. I mean, that makes perfect sense. Let's go to the next slide, prevalence when it comes to back pain.
Yeah, this slide
This is hard to read, so tell us what we're looking at here.
Right, it's a little busy, but the bottom line is, 220 million adults, and of those, 100 million will experience low back pain, and the 12.5 million will have chronic low back pain, and that's defined by back pain that lasts for greater than 6 months. And if you look, we're talking about non-surgical management, but we can't talk about non-surgical management without addressing the surgical management. Okay. And that, if you go to the right of the slide, you're looking at the 20% of people that have a diagnosis that, like, say, disc herniation, where you see that the disc is herniated, it's pushing on a nerve, and that needs surgery, okay? We'll try to treat that conservatively, but generally that's a surgical problem. Spondylolisthesis is a fancy name, and that just means that you have a slip of one vertebral body over another, and that obviously can cause problems with the neural elements too, and that probably needs surgery. Spinal stenosis is something that generally happens as we age, which is a narrowing, again, compression on the nerves, and the VCF stands for vertebral compression fracture, and that's where we can actually do some different procedures to try to correct that, and then tumor, which is less common in the spine. So those are the surgical indications. The other 80% of folks that have back pain don't need surgery. And so what could be the actual causes of their pain? And there's several different structures in the body that can do that. The sacroiliac joint, the hip joint, the facet joints, and the disc.
Okay, what does this slide have to tell us?
All right, so
three-column.
The three-column model, a lot of the spine, in the field of spine care, there's a school of thought that divides the spine into three columns, the posterior, middle, and anterior. And I'll show on this model that basically, if you turn to the side, the posterior column is everything in this is the patient's belly and this is their back.
Right.
And so this is the back of the patient, and that is where the muscles run up and down, and these are the bones you feel on your spine. Mm-hmm. And then you have these joints on the back part of the spine, the facet joints. In the middle is all the neural elements, where everything that you see is yellow, is the spinal cord, which technically it's not at this level, but also these spinal nerves as they exit. And this red thing indicates a herniated disc there, which we can talk about later. And then the anterior column is this front part where you have the vertebral bodies, the intervertebral discs, and those structures, which we'll go on to discuss further.
Once again, what's the middle column?
The middle columm is, another term for that is the neuroaxial column, or everything in the middle. So you have the front here, and you have the back here, and the spinal canal is where from the brain it runs down and goes out, and that's the middle column is made up of all the neural elements, so all the nerves.
Three columns. Let's go ahead and dive into this even more so. The next slide, posterior. Muscles, ligaments, and the joints.
All right, so the posterior column is, as we discussed, is made up of muscles, ligaments, and these facet joints, and these joints are at the back of the spine.
Let's go ahead and come back on set, and he's going to show here on the spine.
All right. I don't know if you can get a close-up, but these are the joints.
Right there you go.
So you see they're paired joints, and they're actually synovial joints on either side of the spine, and it's made up of one upper and one lower, and they come together, and these are the joints that help us with kind of limit both flexion, extension, and rotation of the spine. And these are paired joints all the way up the spine from the neck all the way down.
So pain can come from this area?
Yeah, these joints have a nerve supply.
They have a nerve supply even though the yellow part is not touching, or is it touching that area?
Well, this model's not complete. So there's actually small branches off of these yellow nerves, off of what's called the dorsal ramus, which come around and supply these joints. And each joint, anatomical studies have showed, is supplied by two different medial branches.
How do you, the specialist, know that that's where the pain originates from?
Well, that's an excellent question. I mean, multiple studies have shown that there's certain things on clinical exam that we can be suspicious for facet joint pain, but the studies have shown that the only way to diagnose it for sure is to, if I think you have facet joint pain, we bring you in, and I'll either, under x-ray, anesthetize the nerve that supplies that joint, or stick numbing medicine directly into the joint. And so if we think that that is the painful structure, your facet joint, and we make it numb, then in theory your pain should go away. And if your pain goes away for a diagnostic period, then that's diagnostic. And we can say, okay, now we know we have a diagnosis. Your pain is from the facets, so that will help direct our treatment.
All right. And before we get into treatments, let's continue on with our slides. So the neck shows a disc, or basically what we've seen here on set here with the slides, right?
This is a better schematic representation of what I was just showing you. And so you see on the left you have a joint that has its intact capsule, and on the right side you see where that capsule's been removed, and you can see this is actually a true synovial joint, just like other joints in your body.
And all of that is being fed by the nerve supply, too.
Yes, sir.
All right, in the next slide, now we're talking about the middle column.
Right, now we're moving on to the middle column, and that's the epidural space, the spinal cord, the neural elements, and the nerve roots, which we described everything in this actual model here, everything that's yellow. And so those are the things that mediate the pain.
And the next slide is an MRI, and what is this showing?
Yeah, this is actually a fluoroscopic X-ray or a visualization of what we call a transforaminal selective nerve root block. And what this is, you see the needle, the thin line coming in from the right, and then all that dark stuff is the contrast dye, which is outlining a particular nerve level. So if I think you have a herniated disc and it's pushing on your L4 nerve, I can target that specific nerve and numb it up. And if that makes your pain go away, that will, and then I can put steroids in there to try to help you, but it's diagnostic and it's a positive predictor for you having a better outcome with surgery. So this is actually a representation of a spinal injection that we can use to help. Again, an accurate diagnosis leads to an effective treatment. So this helps us find the diagnosis.
All right, and then we move on to the anterior, the next slide.
Right. The anterior column, like we discussed, is the vertebral bodies and the intervertebral discs. The vertebral bodies are really what most people think of when you think of the spine. And if those collapse as you age, you can have osteoporotic vertebral compression fractures, and that's outside the scope of this discussion. But right.
Once again, this is the area that's touching the stomach.
Yes, sir.
Okay.
Right.
So this is the anterior.
Right. And then these are the intervertebral discs. So they're cartilaginous shock absorbers between the bony elements. And both the intervertebral bodies and the vertebral bodies and the intervertebral disc are what make up the anterior column.
Interesting. The next slide talks about disc pain.
Right. So basically, as it shows on the left, there's a healthy lumbar intervertebral disc, and that the yellow part, it is actually like the jelly part of a jelly donut. So that's what we call the nucleus of the disc, and that has it's a soft, really like a jelly part of a donut, and then the outer white part is more firm, and you can see the nerve fibers from the adjacent neural elements. So the outer third of what we call the annulus, or the thick part of the donut, has nerve supply to it. On the right, you see that this intervertebral disc has what we call internal disc disruption, and that's exactly what it says. It's internal to the disc, and the annular fibers are disrupted. So you start to see these cracks or fissures in the disc, and then what happens is that nuclear material can leak out into the disc. And embryologically, the way we form, that has phospholipase A2 and a lot of other, just let's say, bad actors that can cause irritation when it gets onto those nerve fibers.
And that's what we're looking at on the right-hand side.
That's what we're looking at on the right-hand side. So that's somebody that on an MRI, they're not going to have a big herniated disc. That disc will look relatively normal, other than possibly what we call a high-intensity zone, which would indicate that they have an annular tear. So discogenic pain, which is what we're discussing, is pain that's contained to the disc itself.
All right. I think the next one is an MRI visual, or is that another X-ray?
Right. That's an X-ray, or what we call fluoroscopic view of a procedure we call diagnostic provocation discography. And this, in all fairness, is a very controversial procedure, but it's used, it's very simple. If we think that your discs are causing the pain, then it doesn't matter what they look like on MRI. We have to determine if we can provoke that disc and reproduce your pain. So what this does is we actually have the patient on the table, and we direct the needle into the nucleus of the disc, fill that up with contrast dye, and if they have these tears, it should cause their familiar pain. And if we can provoke the pain they live with every day, then we can confirm that disc is their pain generator, and it will help direct our treatment.
All right, and we're going to get to the treatments here in just a few minutes, but we're going to continue with the diagnosis. Now, the next slide, another visual as to actually other causes
Right.
first.
So the other causes are the sacroiliac joint, the hip joint, a piriformis syndrome, which is a muscle that runs near the sciatic nerve that can kind of mimic sciatica. Abdominal pain, the organs in the abdomen or the pelvis can sometimes mimic back pain. And again, cancer is a less common cause.
All right. Now, when you see these other causes up on the screen there, it takes a little while to determine if that is what the problem is, as opposed to going through a spinal issue, correct? I mean, how does this work?
Well,
by the time you would get other causes, how much time has lapsed?
That's one of the reasons that not a whole lot of doctors like to deal with back pain. because back pain it can become, as you can see, it's from multiple sources, and it's sometimes very frustrating to treat. So one of my partners, I think, I agree with his statement. It's just like saying I have chest pain. Well, if you go to the emergency room with chest pain, that's a symptom. But that could be a heart attack. It could be a pulmonary embolus. It could be something in your esophagus. You know, there's multiple reasons. So again, an accurate diagnosis will lead to an effective treatment. Back pain's no different. Doctor, I have back pain. It's up to us to figure out where's this back pain coming from. And if they've gotten to the point where they have neurologic changes, you know, they need to see us. Or if it's beyond 6 weeks and they come to see us, then we have to be the detective and say, where is this patient's pain coming from?
And you as the specialist, do you have conversation with other doctors? How does this work to make sure that you're on the right track?
Typically, that's what our specialty is. So if they're coming to us for back pain, then we are the primary specialists that will determine what is causing this pain. Obviously, if we find out it's a tumor in their pelvis that's causing their pain, then we'll refer them on to the appropriate specialist.
Right. Okay. So in their mind, it's back pain, but it could be something else.
Right.
And that's what your job is to try to determine that.
Right.
All right. And that's why the other causes are up there. All right. Next slide, another X-ray. It shows
right. This is
condition.
A fluoroscopic X-ray, which it's a little difficult to correlate, but that is a SI joint or sacroiliac joint injection. The line coming in from the bottom is the needle, and the contrast is going into the sacroiliac joint.
I don't know if I follow you now.
If you pan to this model, I can show you.
Okay, let's come back on set here. Let's make sure we understand what we're looking at here.
All right.
Jason's going to get it in just a second. Here we go.
Okay, so here's the spine. This is what we call the sacrum, and the ilium fit here. Okay.
The what?
The bones of your pelvis. You know,
right.
You think of your
so
pelvis.
I'm looking at the back side.
Right. You're
back.
looking at the back side, and your pelvis fits in here. And so this is the sacrum that starts with a S,
okay,
and the ilium that starts with an I. So we call that the SI joint. So we're talking about the joint right here that can cause can cause pain.
Okay.
Okay. And that previous slide was just an
We're
example.
We're going to go back to it in just a second. So
okay.
Now we're actually looking as to where the treatment is. Where's the needle? I don't see that.
The black line coming in from the bottom of the picture that kind of curves around into the darker. That's contrast, and then it's difficult to see. But this is
No,
actually
I think we get it.
good.
We understand where you're coming from. But what's the treatment? Is this still diagnosis or is this treatment?
Yeah, absolutely. There's particular things that we suspect. If we think your pain, you come in with back pain and we think it's coming from the sacroiliac joint, and we do different things to diagnose it, different things to treat it, imaging studies, and you're still not getting any better, we can actually, under fluoroscopic visualization, put a needle into that joint, see if we can reproduce your typical pain, and then inject local anesthetic and steroid into that. And if that gives you relief, then we've confirmed that this is your pain generator.
And then that's when the treatment process actually begins, what the next step is, once that's been discovered.
Right.
Very good. I think I understand it. Folks at home, I hope you do too. Let's go to the next slide. And it's the same patient, I believe, but what are we looking at here?
Basically, this is just a representation of a hip joint.
No, that's a different patient, isn't it?
Right.
Yep. Okay.
Where the hip, I think it's fairly easy to see the ball of the hip, and the needle's coming in from the left bottom side of the picture, and you see the contrast dye spreading around the top, or what we call the head of the femur, that ball-like structure.
Right.
So that joint is like a ball and socket joint, and if we think that your hip is no different than your knee joint causing pain, but we can inject your knee joint in the office. And you know, the hip joint, to make sure that the medicine's going in and around the joint, we can confirm it under fluoroscopic visualization. And if this reproduces pain in somebody's hip or groin or their low back, then we can say, okay. And it's not, you know, it's not mutually exclusive. You just like your car can have a muffler and a transmission problem, you may have a spine problem and a hip problem.
But this helps determine with the specialist if it's a hip problem versus a back issue.
Right. Correct.
Okay. Very good, very good. We're starting to get some phone calls, but we have a few more slides to get through, so let's see if we can do that before we take a couple calls here. The next slide does address some treatment. So let's go to that slide if we can.
All right, so the initial treatment algorithm is anti-inflammatory medications, physical therapy, different modalities like heat or a TENS unit. Even some patients seek alternative treatments. Chiropractic and acupuncture can be very helpful for some people. Steroid medicine by mouth, where you take what typically people understand a Medrol dose pack, 6 pills, then 5, then 4, then 3. And this is, again, all directed at reducing the inflammation. And then selectively placed corticosteroid injections, which is all the things we've just been showing, that you can actually put instead of taking it by mouth and having your whole body exposed to it, you can actually place the steroids directly on that particular structure and try to give you more intensive relief.
And how long does that last?
Everyone's different. The average is about 3 weeks to 3 months. But the analogy that I would use is, because this is a great question that people ask all the time, and the analogy that I found best is, if that inflammation going on inside of your body is like a fire, the maximum amount of medicine I can put in at one time is like a bucket. So I got a bucket of water. So if you have a campfire, one shot will put it out. It may last, in your mind, forever, right? If you have a brush fire, it may take a couple buckets. If you have a house fire, it doesn't matter how many buckets I pour at it, you're going to end up needing surgery or some other treatment.
I see. So when you get the results from patients saying, I had these injections, they didn't do anything for me.
Right. Well, that's the analogy I give to patients is, if everyone on your street gets new brakes for their car, it's going to work great for the people that needed new brakes, but the people that had a muffler problem, it's not going to work great at all. So we have the whole gamut of people that come in and say, my neighbor said it was the best thing that ever happened, or everybody I know said it was the worst thing that they ever did, and don't do it.
Right.
But again, that goes to an accurate diagnosis will lead to an effective treatment. And that again, if the viewer can just remember that, and this is what we pursue, find out what the problem is and then try to make it better, rather than these random treatment options.
All right. We did have a caller, and I understand that he dropped off, but wants to know what can be done for scoliosis.
Most scoliosis people can live with, but the scoliosis that develops to the point where it's...
What is it, first off?
Scoliosis is a curvature of the spine. And typically, if that progresses rapidly enough, then that can cause compression on the nerves and some other structures, and that may end up needing to be surgically corrected.
All right.
Sometimes bracing is an option as well.
Another series of x-rays. Let's go to, what are we looking at here?
This is just something, an accurate diagnosis leads to an effective treatment, but even the treatment has to have some science behind it. And this is what we call an interlaminar epidural, where the needle goes, just like when a woman would have a baby, and they actually put the needle in from the back. You can see on the picture titled B on the right, that's a lateral view, as if you were looking at the patient lying on their side. So everything on the left-hand side of the picture is their back of their spine, and on the right-hand side is the front of their spine.
Okay.
So if you're trying to treat a problem in the intervertebral disc, which you can see on the right-hand side, but you do an epidural, a typical interlaminar epidural, you can see that contrast dye, the white stuff, the bright white stuff, will just layer out posteriorly.
Oh, yes.
So even though they've had an epidural steroid injection, this is not going to help that person. So then they go back to their doctor and say, well, I had epidural steroids and they weren't helpful. And so not only do we need to have an accurate diagnosis, our treatment needs to be very specific to get the medication to the painful structure.
That really does visualize that, doesn't it? Let's go to the next slide, treatment options, I believe.
Right, and this is treatment options specifically for disc degeneration, and this is where the emerging treatment options are coming into play. The top of the slide is where we manage the patient, and that's, my job as a non-surgical specialist to implement the conservative therapy, find out the diagnosis, and do the appropriate treatment. And sometimes that includes interventional therapy. Typically, up to this point, the only other option as the disc degenerates or as this cascade continues, then there's other surgical alternatives like replacing the disc, doing, decompressing the disc if it causes stenosis, or fusing the disc. So prior to this new therapy, which is this biologic therapy, which actually can repair or regenerate the disc from the inside, which would introduce an entirely new category between both the conservative therapies where we just manage or the surgical therapies where we remove, replace, or stabilize.
All right. Well, there you go. And as we said at the top of this show, Dr. Vandenoord certainly hopes to get across some of this emerging research that's taking place here in Charlotte. It sounds very interesting, and we're going to tackle that as well as take your calls in the second half of the show. We're going to take our break. You're enjoying HealthWise on WTVI.
HealthWise is brought to you by OrthoCarolina, a comprehensive orthopedic practice with locations throughout the Charlotte region. OrthoCarolina, excellence in orthopedics, on the web at orthocarolina.com. And by the Mecklenburg County Health Department, and by viewers like you. Thank you.
Dr. Ronald Vandenoord from OrthoCarolina is here to review back pain from a non-surgical perspective, and he's here to share with us emerging research as we're exploring back pain today and tomorrow. So what's the emerging research, and it's happening here in Charlotte?
Right. We've been very fortunate and privileged to be included in a multi-center trial. It's one of 15 centers throughout the country where this company has invented a product which is a fibrin matrix. And what that is they combine two naturally occurring things in your body, fibrinogen and thrombin.
What are those?
Those are parts of what we call the clotting cascade.
Okay.
So you know, in the body, if you get cut, your body forms a whole response to clot, to stop the bleeding. And those are the two elements that, when they come together, they form a stable fibrin clot. And this has been used safely in surgery for 30 years in millions of patients. But this company has come up with the idea that if we can inject this into the disc and actually heal the disc from the inside, that this may be a whole nother alternative to treating low back pain.
That has to be exciting for a specialist like you.
It's very exciting. I'm very honored to be a part of it, and I work with 3 other specialists that do what I do, as well as multiple other surgeons in the spine component of OrthoCarolina, and we're all very excited about it.
And you're one of, what did you say, 15?
One of 15 sites in the country, right? And the Virginia is that actually hasn't gotten established yet, but all the way up to the Northeast and down to Florida. So we're very excited about the opportunities for the patients in this area.
Okay, let's explore this a little bit more. Let's go to the next slide and explain to us what we're looking at here. Is this all part of the research?
Right. This is, you know, what I was stating about the fibrin sealants, that these are surgical tissue adhesives made from human blood proteins, the fibrin and the thrombin. Okay. And when you mix these two together, it will replicate the final stages of the blood coagulation cascade, and it forms this stable fibrin clot. Like I stated, it's been used for several years very safely in the human body. So, you know, I know the first thing callers will say is it safe? And the answer is absolutely, it is safe.
So what is this depicting on the left-hand side, the pictures?
That's just a microscopic view of the fibrin, of basically the thrombin and the prothrombin coming together to form the clot.
Why does it look thicker up top as opposed to the bottom? Is it supposed to?
Basically, that's forming the stable fibrin clot.
I understand. Okay. Now, Dr. Vandenoord has brought us a little clip of video. It's animation, and he's going to explain what we're looking at. It's fairly quick, so let's go ahead and roll the tape, and Dr. Vandenoord explain to us what we are looking at here. All part of this emerging study.
What you're seeing here is the needle going into the disc, going into the very center part of the disc, which is that nucleus, and you see these cracks and fissures coming up. And then you're going to inject the fibrin sealant into the disc, and it will seal the cracks from the inside. So that's basically a very helpful representation of what we're talking about.
Interesting.
Yeah.
Is that painful for the patient? Is he or she, is there a local or a general that they're put under for this?
It's all done as an outpatient. We generally will sedate them, so a lot of times they don't remember it at all. But it does require placing a needle through the skin and into the disc. So there is some discomfort with it, but again, most people tolerate it fine.
How long is the procedure? Do you classify this as a procedure?
Yes, this is a procedure, and it's an outpatient procedure,
Right.
and the procedure itself takes less than 30 minutes generally.
Okay. All right. We do have callers, so let's go ahead and go to the phone bank. We have Dane with us from Charlotte. Hi, welcome to the show.
Hi, thank you for taking the call. Doctor, could you explain or show on your skeletal there that about 30 years ago I broke a transverse process in my lower back, and it was athletics, and I had to finish the season and play with it, and they said if you could live with it, you know, you can play with it. This week, almost the identical same spot, the identical same symptoms show up. It's very painful, especially to sit. Could that be related to, or could you kind of help me understand, when I broke this transverse process, it was a football injury, and if it could be flaring up again, or if I could have the same identical thing going on?
Right. That's a great question, Dane. The transverse process is this piece here, and it's not an uncommon injury in football to fracture that transverse process, but it's similar to a rib fracture. Typically, there's really not anything we need to do, and it usually will heal on its own, unless there's some neurologic injury or there's some instability. I would say, if I understood you correctly, that happened so long ago, if you're having back pain at this point, it's very unlikely that it's that transverse process again. I mean, it's possible, but unlikely. And I would say come in to see somebody and see if that we can get to the bottom of this and find out if it's that or it's something else. Because I would say, if I had to guess, it's likely something else that's causing your discomfort.
Dane, we appreciate the call, and good luck to you. I hope that helped with him showing you exactly where this pinpoint is. Joan in Mount Holly, welcome to the show.
Hi.
Hi, what's your question?
I have, well, I went to this doctor and he put a shot, a nerve block in my back, and it's what wore off now, and tomorrow he's going to put another one in, but I was wondering, since I've got an aneurysm in my stomach, is it coming from it or causing the pain?
And better yet, is that a risk for you to have a procedure like this, too? Let's hear what he has to say.
Is she still on the phone?
Yeah, Joan, are you still with us?
Yes, I'm still on the phone.
I got one question. When he did the injection, did it take your symptoms away for a period of time?
About 3 or 4 months.
Okay, so for 3 to 4 months after the shot, you did a lot better.
Oh, I was wonderful.
Okay, well, I can answer your question. That's the whole point of what we've been talking about, is that's diagnostic. Okay, so that means that not only are you having pain from your spine, you're having pain from that part of your spine where he did the shot. And it's the bucket and fire analogy, that he just needs to put another bucket of water on that area. If it gets to the point where you have any progressive numbness, tingling, or weakness, then it may be that we're not able to put the fire completely out, and you may need surgery. But as far as the risk of your abdominal aneurysm, certainly that's always a risk. With that can be a problem at any point, even when you're having a procedure. But there's no increased risk from doing the procedure if the physician that's following you for that deems that you're stable from that standpoint. And certainly an abdominal aneurysm could mimic back pain. It's a great question. But based on the fact that you got 3 months relief of your symptoms, then I would say in you that's not the case. Thank you for your question.
Yeah, Joan, we hope that helps. So your advice is, if she's having another one done, I think she said tomorrow.
Right.
She needs to go ahead and consider having that done then.
That's what I would recommend for her.
All right. Well, then there you go, Joan, and the best of luck to you, okay?
Thank you so much.
Yeah, thank you for calling from Mount Holly. You know, it wouldn't be a Healthwise if we didn't have a show or a call from Mount Holly or Gaston County.
Right.
We really have a lot of viewers over in Gaston County, and we appreciate that. Do call us if you can. We still have 15 minutes left on the show. And my email address is jpop@wtvi.org. Okay, for much of this show, we talked about the diagnoses and the diagnostic tools available today.
Right.
And so many treatments out there. So how do you know you're getting the right treatment?
Well, I guess the simple answer to that question is if you're, like for her, she's getting the right treatment because she's getting better. Typically, if you're going to any practitioner, no matter what, and you keep getting treatment after treatment after treatment and you're not getting better, either, they need to acknowledge that they don't have a diagnosis yet, or they have the wrong diagnosis and they're not, or they possibly could have the correct diagnosis, but not really they haven't implemented the best treatment yet.
And then I can just see getting emails from viewers or phone calls the next week. If, in fact, OrthoCarolina is involved with this study of this emerging research, can patients from our region or viewers from the region who are back patients, can they be a part of this trial study?
Yes, lowbackstudy.com is...
Oh, is that a website?
Yeah, lowbackstudy.com.
We'll see if we can get that on the screen, too. Lowbackstudy.com would be the email address for those who are interested in checking out the study that we've been talking about with the sealant,
right,
the injectable sealant. And what is the sealant? Does it end up being like a polymer, or what is that, like a cement? We've heard where some cement therapies are taking place now.
Right. The cement you're talking about is like in the vertebral compression fractures, you can actually inject cement into the vertebral body and fill it back up. This is different in the sense that it's more of a liquid type material, and when it comes together in the disc, it forms this clot, and it will reduce the theory is that it will reduce the inflammation, and it will also form a scaffold of natural material that your body can, again, repair itself from the inside. So that's the unique thing about it.
And in addition to that, because of that, I should say, it takes away the pain.
Right. That's the whole theory. And actually, they did a pilot study where the results are very encouraging, and the patients have done really well.
All right. Let's go up to Newton. We have Nicole with us now. Hi, Nicole.
Hi.
What's your question?
My question is, I have problems with my L4 and my L5 vertebrae. What pain management options can I do other than pain medication? Because pain medication is not working.
All right. And you've been with us throughout the hour, right?
Oh, yeah.
Okay. So here she has been going through pain management with L4, L5.
Right.
For other viewers out there who have gone through pain management, what's their options?
Well, again, I don't want to overemphasize this or beat a dead horse, but I would say using her as an example, the bottom line is I need to know what your diagnosis is. Pain is a symptom. So if you have a headache, you can take a Tylenol and that will treat the pain of headache. But the question is, what's causing your headache? You have L4 and L5 problems, but unless I know what that problem is, there's no way that I can know exactly what to recommend for you. It can be any one of these structures that we've discussed, and I'd be happy to see you and discuss it with you.
Nicole, it's so hard to make a diagnosis over the air, and it may be time, if you've been under the care of one specialist, perhaps get a second opinion and just see what can be done, especially if you're tired of the treatment that you're currently getting. So we thank you so much for calling in, and I'm sure you also asked that question with many other viewers out there in mind. Let's head down to Heath Springs in South Carolina, and we have Joyce with us. Joyce, where are you calling from? What county is Heath Springs?
That's in Lancaster County.
Of course. How are you tonight?
I'm fine.
What's your question?
My question is, in the research that you're doing now, is there any hope of getting anything else for the SI joints, the sacroiliac joints? Mine are completely worn out. I've had every treatment known and been to several specialists and have had no relief at all.
Let's see if Dr. Vanderdorn knows. And also this website that we've put up, if you do have a computer, you may want to look at lowbackstudy.com.
Yes, I will check that out.
Well, Joyce, I would say if your diagnosis is accurate and you have SI joint pain, which it sounds like you've been through multiple specialists and that's actually the case, then have you tried prolotherapy?
That is the next thing on my list.
Okay, that is one option for you that I've had a lot of patients that have recalcitrant SI joint pain that actually do real well with prolotherapy, and I would research that more and give that some thought if that's not something you've done. But I would stay away from surgery. There are some people in some centers around the country that are claiming that if they fuse the SI joint that they'll take the pain away. I personally would not recommend that.
No, I would not recommend it either.
Joyce,
No
thank you.
surgery.
Thanks for the question, and good luck to you. Let's go over to Gastonia now with Monica. Monica, how are you?
I'm good. How are you?
Good. What's your question?
I had back surgery in February of '09. They replaced the disc with a synthetic material, the L5 disc, and it was fine for a while, and now I'm having the same symptoms. It was on the left side initially. Now I'm having the same symptoms to start with a sciatic nerve on the right side. Is it possible to do that, to maybe have it be a different disc to create the same symptoms on the other side, or is what you're talking about something that I could look into?
Oh, interesting question.
I guess I'm not sure if you can answer this question for me, but did you have a disc replacement?
Yeah, they took the disc out, replaced it with a synthetic material. I have a titanium plate and screws.
So you had a fusion?
Yeah.
Okay. It certainly is possible. There's a phenomenon called a recurrent disc herniation where they take most of the disc out, but there's another piece of the disc that can actually protrude either that same direction or on the opposite side, what we call the contralateral side. So it is possible that you have a recurrent disc. It's possible that you have a new disc at another level. It's possible that there could be a lot of other things going on. So I would say if it really is as bothersome as you're describing, as I understand it, I would go back to your healthcare provider or seek another opinion and get that looked into.
I had degenerative disc disease on L3, L4, and L5. Of course, they did the L5, so I didn't know if what the surgery did would be able to correct everything, or like what you're saying, that maybe another disc is bothering it.
Right. Degenerative disc disease is a process that I kid with my older patients. It's as we mature. I don't like to use the word age, but we all will get it. After age 30, we all start degenerating.
I don't want to be mature.
Yeah. Basically, the answer to your question is them operating at one level is not going to solve your degenerative disc disease at multiple levels. So this is a process that just continues over time, and it certainly is possible that you either have a recurrent problem at that same level or you may have a new problem. So I would recommend getting it looked into.
All right, thank you.
Monica,
You're welcome.
Thank you so much for calling. And if it is a new problem, and since she's had a procedure, can she have another one?
Absolutely. Just because they've operated at one level doesn't mean, if it's at that same level, it gets a little trickier. But certainly if it's at an adjacent level, we do see that quite frequently.
Even a fusion.
Right.
All right. Monica, great question, and thank you so much for calling it in. Let's come back to the Queen City. Patrick joins us. Hi, Patrick.
Hi.
What's your question?
My question with you, this new research that you're doing with this clotting stuff, how do you keep those substances from clotting the nuclear material as opposed to just clotting the annular fissures?
That sounds like a deep question.
No pun intended. That's actually a very good question, and actually the fibrin sealant goes through the nucleus into these fissures by pressurization, but it's all that's also part of the normal structure of the disc. So it's not really like you're introducing a different chemical or a different thing. It's enhancing the body's normal ability, or what we call the scaffold, to regenerate and heal. And they've actually done studies where they've confirmed that if it does spread out of the disc and gets on the nerves from the anterior column into the middle column, that it's shown to be safe as well. So that's an excellent question.
Patrick, thank you so much for that insight. And we may roll that piece of animation one more time for new viewers to see. Brenda joins us now from Shelby. Hi, Brenda.
Hello.
Hi, what's your question?
I have a degenerative disc in the L4 and L5, and now it's moved down to the S1 and S2, and I was wondering if this procedure would help that. I also have arthritis and a pinched nerve going down my left leg.
When you say this procedure, what we had shown in that animated clip?
Yes, sir.
Okay, we're going to go and roll that clip one more time as Dr. Vandenor addresses your question here and explains to us what we're looking at in case we have new viewers who have just joined us here in the second half of the show. Dr. Vandenor, let's retouch this.
All right, we're looking again at the spine, and you'll see a needle enter into the disc, into the nuclear part of the disc, which is that center jelly part of the donut, and then this fibrin sealant will seal all the cracks from the inside. Brenda, I would say in response to your question, I don't know. You have 4 or 5 degenerative changes, and it sounds like it's moved down to S1, S2. Certainly, it probably has involved L5, S1 as well on the way. And the best answer I can give you is you need to come in and talk with me about it and see if you're a candidate, or you can go, if you have computer access, to that lowbackstudy.com, and there's a screening process there where they can get you started.
Okay, I sure do. Thank you.
You're welcome.
Yes, and good luck to you. Thank you so much for calling us. So as you can see in that animated clip, it's the sealant that goes into the cracks in the disc itself. When could something like this be FDA approved?
We're in a phase 3 clinical trial. And
what does that mean?
That basically means that they've gone through the pilot study, and it's a FDA controlled clinical trial, and so I have the 15 centers have the opportunity to perform this for both safety and efficacy. The question of when it will actually be available, that gets into, if we can prove efficacy and the FDA approves it, you're looking at a couple years down the road.
All right, we thank you so much for filling in on that. Now we just have a couple of minutes. I want to talk a little bit about background here.
Okay.
You have been in Charlotte for a while, but you're not originally from here.
Right.
We just discovered before we went on the air that we played football at the same high school in Atlanta.
Right.
But I'm much older than you are.
Right.
But what brought you to the Queen City, and how long have you been practicing here? And you're at several locations with OrthoCarolina, correct?
Right. I initially came to Charlotte to work with Charlotte orthopedic specialists, and then we merged with the Miller Clinic, and it's been very successful. Now we're called OrthoCarolina. I've been here in practice 10 years, and ironically, my wife was born at Presbyterian Hospital, so we claim some native
there you go.
To the Queen City. But.
And for patients to find you, they can go through our website or call our office here during the week, or you could email me, jpop@wtvi.org, or find him through OrthoCarolina. Very quickly, Mark from Charlotte, what's your question? You with us?
Yes, sir.
Hi, what's your question? We just have another minute and a half.
5th, 6th, 7th vertebra, could that cause headaches coming across the right hand side from the shoulder up to the center of my right eye? And can that cause also balance disorder?
You're talking about in your neck, correct,
yes.
Mark?
Yes,
okay. Sir. The answer to most of your question is yes, and I would definitely go see a specialist. It'd be uncommon for that to cause eye pain, but as far as the headaches and the shoulder symptoms, that can definitely be coming from that part of your cervical spine. Yes.
Mark, good luck to you. You know, that has to be tough. You know, most of this hour we've been talking about lower back, but for the neck area too, if you're having issues, go see a specialist. That's the bottom line here. And as he has said throughout this hour, be sure and get the right diagnosis. And it may take a little time to get that.
Absolutely. An accurate diagnosis leads to an effective treatment. That's the take-home.
That's the take-home right there. And if you feel like you can't get it done in that first or second visit, have patience with that specialist and look at them straight in the eye, as you said, and say, what's my diagnosis, Doc?
Absolutely. And sometimes they have to answer. Sometimes the answer is, I don't know. But oftentimes in the spine, it can, for those rare patients, become a lengthy process where we're really trying to sort out one thing over the other.
Dr. Robert Vandenor from OrthoCarolina, we thank you so much for being here. He is at several offices, including Matthews, the Spine Center in Uptown Charlotte, as well as the new center there on Caswell Road, correct?
Right. University.
And
Monroe.
And Monroe. So there you go, Dr. Robert Vandernoord from OrthoCarolina. We thank you so much for joining us. As always, we hope that this medical broadcast has helped you become more health-wise. Now, if you didn't have a chance to email your questions in, do it even though the show is just about wrapped. jpop@wtvi.org. I can get those questions to OrthoCarolina, Dr. Vandernoord, and he can certainly address those. And also, you're welcome to call us here at the station, WTVI, during the week to ask your questions, and we'll make sure that they are addressed. Be sure and join us. We have several shows left in this season. Make it a great week.
If you would like support group information about tonight's topic or any HealthWise topic, call SupportWorks at 704-331-9500. If you have a comment or question about HealthWise, call 704-371-8836 or email us at healthwise@wtvi.org or go to the website wtvi.org. If you are interested in being a guest on HealthWise or like to sponsor a HealthWise program, please call Suzanne Milkey at 704-372-2442. Learn more about HealthWise and other local productions at WTVI.org. Go to our website and you will see current and upcoming events on air and in the community. That and much more at WTVI.org.